to our event, The Science of Relief in OADs, the Synchrony of Device and Drug. We have an esteemed faculty helping this program, and I would like to introduce our moderator for today's event, Dr. Rushika Shah. Dr. Rushika Shah is an Associate Director in Cipla Respiratory, the medical team, and she manages the COPD, nebulization, and orals portfolio. She has been associated with Cipla since 2020 and was involved in the setting up of the Breathe Free Lung Wellness Centers, which are India's state-of-the-art respiratory wellness and diagnostic centers. She was also a practicing consultant pulmonologist in Mumbai from 2013 to 2021 and has worked closely with the bedaquiline and delamanid compassionate programs for drug-resistant TB patients during her tenure as a pulmonologist. She has multiple abstracts and publications to her name, with 3 chapters to her credit in the fields of tuberculosis and sleep apnea. So handing over the session to you, ma'am.
Thank you, Sanjana. Thank you so much for the kind words of introduction. So in today's session, we will be mainly covering the important aspects which we see along with, just one second. Yeah. Hello and good evening, everyone. And sorry for the technical glitch which I had at my end. Obstructive airway diseases we know the huge burden of obstructive airway diseases which are seen in our country in our day-to-day practice. And along with that, the burden of exacerbations comes into the picture, which really brings a big burden of poor quality of life in patients, and along with that drills a big hole into their pockets. These exacerbations are very critical to manage because the way you manage them shapes the future of these patients, shapes the quality of life of these patients, and any delays in management can bring an overall impact on the life of these patients. And in order to manage these patients well, it is very critical to understand which drug to select and which device to select. And hence, to bring about this discussion today, we are having this webinar on drugs and devices and their synchrony in management of exacerbations and obstructive airway diseases. And we'll be starting this webinar today with a session on the same by Dr. Omar Osmani. I think Dr. Omar Osmani needs no introduction, but still, he comes from London. He is the professor of respiratory medicine and a consultant physician at the National Health and Lung Institute and the Imperial College of London in London. He is an international authority on aerosol science and inhalation medicine. He's done phenomenal work on understanding the therapeutic aerosol deposition and clinical effectiveness in inhaled drug delivery to the lungs. He's received the award for his best thesis in 2005. In 2015, he was awarded the Thomas T. Mercer Award for his international research excellence in pharmaceutical aerosols and inhalable materials. In 2019, he was awarded the Fellowship of the European Respiratory Society, and he is the ERS Science Council Chair and current past president of the International Society of Aerosols in Medicine. So over to you, Dr. Omar Osmani. Please enlighten us with your thoughts on breath-actuated inhalers, their principles, and the evidence which is currently existing around breath-actuated inhalers in the management of OAD. Over to you, sir.
Great. So, Dr. Shah, thank you so much for the introduction. Thank you very much for the esteemed panel. I know we'll have a really good in-depth discussion, and also Dr. Gogte, JD, it'll be good to have a fireside chat with you after I give you my presentation. So I'll start sharing my screen. And while I do that, really, your point that you raised was very much related to the device and the drug. And I think the key thing is that we need to consider the device. You put the context of the importance of obstructive airways disease, not just in India, but globally. And really, this is what I'm going to do now, is I'm going to give you a scientific appraisal. So we have got studies here, and I want to bring out the science, but the key point of the science is what we can do in our daily practice on Monday when we see patients with asthma, COPD, not just adult patients, but pediatric. I did a webinar about 2 years ago, and with the SynchroBreathe device, which is a breath-actuated metered-dose inhaler, there's been a lot of clinical data published in the last 2 years, and I will be capitalizing on that in terms of contextualizing which device should we choose for our patients. So I'm going to go through these 4 aims and objectives, and we'll start off with the historical perspective that we have on inhalers, and really one key slide that will just give us a whole uh, uh, um, uh, a whole perspective on this. So there we go. Right. So we wrote an article on the key moments in inhaler device evolution. If you look on the graph on the left-hand side, inhalation therapy started off in India and in Egypt in 2000 BC. And at that time, they used Datura stramonium, which is an anticholinergic. These are the leaves of the Datura stramonium plant. It's a white flower. These leaves were crushed. They were put into a pipe and then they were inhaled. And in Egypt and in Greece, they used to put these leaves onto hot bricks and they used to inhale. And when you read the original articles that were written about the initiation of Datura in 2000 BC, you can actually appreciate that in the text, it was written inhale slowly and deeply. So you see the trajectory then on the top. You can see Hippocrates, then American Indian pipes, then atomizers, then inhalation smoke, and cigarettes were given to patients with Datura in the 1900s in the UK. And then the metered-dose inhaler was invented in 1956. And you see that in the top line in a circle. But if you move then on and we jump forward, going on 50, 60 years, there's been a lot of evolution. So we have dry powder inhaler devices. We have metered-dose inhalers, which have evolved, and we've got nebulizers. And really what I want to talk today about is the role of the breath-actuated metered-dose inhaler, which you're familiar with. You're familiar with as Synchrobreathe, and really its positioning and how it is advantageous compared to some of the other inhalers. So if we move on, let's talk now about inhaler choice. It's actually quite straightforward. We have 4 inhalers that we can use: metered-dose inhalers, dry powder inhalers, nebulizers, and spacers. These are the usual inhalers that we have when we decide on treatment for our patients. The problem is we always focus on the drug. We don't really focus on the inhaler device. And the management in respiratory medicine is a combination of the drug and the device. And we forget this. And we're not taught this in medical school. So really, it's quite important for us to know about the role of the device. Because if it's not about adherence, and it's not just about compliance. If you don't choose the right device for your patient, and that patient cannot engage with that device properly, then the fantastic drug that's inside it will not get into the lungs and will not be able to give its pharmacological effect. So we now know with GINA 2025 and GOLD 2025 and being updated to 2026, that they both stipulate now you need to match the inhaler with the patient's inhalation ability. It's clear in the GINA circle that you see on the top, and also in the GOLD 2025 directive. And interestingly, I've put on the bottom there, in dark blue, in the dark blue box, GOLD specifically say, be careful of dry powder inhaler devices, because they do require a very forceful deep inhalation, and many patients with COPD and obstructive airways disease and asthma are unable to struggle. Look at the orange box on the bottom right. It's stipulated that nearly up to 50%, if not more, patients struggle to inhale from a dry powder inhaler device. Now, that might be surprising. And the question is why? So let's go back to basics. With metered-dose inhalers, our traditional ones, the biggest problem is our patients shake the inhaler and inhale too quickly and too fast. So one thing we can do with our patients when we go back to clinics on Monday is assess their metered-dose inhaler and make sure they inhale slowly and deeply. So when you ask me how slow is slow, how deep is deep, essentially they need to inhale over 5 to 7 seconds after actuation. It is a really slow, gentle, comfortable, natural, deep, and smooth breathing maneuver that lasts 5 to 7 seconds. And once you relay that information to patients, they actually are able to engage better with metered-dose inhalers. And the problem, is when you inhale too fast and too quick, a lot of that drug can go to the back of the throat. Now, look at the bottom. Dry powder inhaler devices require on the patient's lung muscles doing the work. What do we mean by that? Our primary and secondary muscles of respiration, they need to really be tense to then generate a strong inspiratory flow in order to do three things from a powder device. The first is break this powder up. The second is carry this powder out of the device, past the throat into the lungs. And the third is to allow effective deposition. And as we've seen, the GOLD directive, nearly 50% of patients cannot inhale effectively. And here, high flows are sometimes needed from these dry powder inhaler devices. You can see that as a second bullet point. Some require more than 60 liters per minute, and many of our patients can't do this. So what's the evidence for this? Well, peak inspiratory flow is becoming recognized as a key parameter. So when we come back to our patient in front of us and with the device, and we're selecting the device, one of the things we need to think about is, does this patient have the requisite inspiratory flow, inspiratory muscle strength to achieve therapeutic success from their dry powder inhaler? And you can see clearly here, peak inspiratory flow is a key parameter. And this is the evidence that actually shows that many of our patients do not generate the requisite peak inspiratory flow. This is a really nice study. It was done in Ireland by Richard Costello's group. And what they did was they put an objective digital monitor onto a dry powder inhaler device. They gave this to patients to use in real life. Then after 2 and 4 weeks, they collected the data. What did they find? Look at the graph. The x-axis presents you with the dry powder inhaler errors, and the number one error that was found in nearly 50% of patients was patients had insufficient peak inspiratory flow or peak inspiratory flow rate. So this was objective, electronic, digital monitoring using an acoustic recorder attached to the dry powder inhaler device. So this was really nice data. This is the largest real-world data, and this was the pivotal study. It was done across multiple sites, but co-anchored in the Netherlands. And basically, they found three types of patients. One, there are patients in green that are able to achieve the peak inspiratory flow. Two, patients in blue who can achieve the peak inspiratory flow, but have to be emphasized, have to be told clearly, you really got to inhale deeply and forcefully for a dry powder. Then there are those in the red group who cannot do it, and they have inspiratory muscle weakness. So in nearly 1,500 COPD patients on the right-hand side, you can see in that pie chart, 30% in real life had suboptimal peak inspiratory flow. So what's the implication on this in our clinical practice when we go back to patients on Monday? We will see our patients, we'll give them a DPI, we'll think it's easy for them to use, but we won't assess their ability to inhale appropriately. We think that they will get pharmacological therapeutic benefit, but the reality is they cannot engage with that device to be able to trigger it in order to get the drug into the lungs, and therefore they won't be able to get effective treatment. So this brings us into the sphere now of the breath-actuated pressurized metered-dose inhaler. So these are automatically triggered by the patient's inspiratory effort. So let's look at this point. They do not require your patient to take a really deep, forceful, hard inhalation. They require you to take a gentle, slow inhalation. So the maneuver is like the traditional breath metered-dose inhaler, but these are breath-actuated. So it's a gentle maneuver, and basically the device is then activated. And you see that here with the Synchrony that we're going to be talking about. The second point is breath-actuated devices are useful for older children and adults who have difficulty coordinating triggering with inhalation. And we will be looking at examples of this and also examples of children who have special needs. So you can see that the breath-actuated metered-dose inhaler covers different patient populations and different kinds of inhalation technique to give us, the clinician, reassurance that when we give this device to our patients, that actually they are going to get therapeutic benefit from the drug in the clinical trials. So let's move on now to Synchrony and positioning it amongst the other inhalers. This is a narrative that I wrote with Federico, JD, Dr. Gogte, and also Vaibhav Gore, Dr. Gore, and Sundeep Salvi, and really it was about summarizing the data on Synchrobreathe as a breath-actuated pressurized metered-dose inhaler. And I think you're lucky in India because you have the technology of a breath-actuated metered-dose inhaler across a variety of drugs, and we'll be seeing the variety of drugs a little bit later. So I don't need to explain this to you because I think you're familiar with it. But essentially, the SynchroBreathe is there. It's shown clearly to you. If you look on the left-hand side, there is a dome shape, there's a small orifice, there's an integrated dust cap, there's a spring and an inhaler engine. So if you look on the right-hand side, I've highlighted that the spring gives you the energy. It is set, the inhaler engine is sensitive to the very gentle inhalation maneuvers that are required. And when we're talking about gentle, between 30 to 35 liters per minute, which is very low to activate this device. Unlike some dry powder inhalers, which require high inspiratory flows of greater than 60 liters per minute. So here what you see are the correct steps of use. It's like a metered-dose inhaler. You shake it, you open it, you hold the device upright in the upright position, you breathe out gently, place the mouthpiece, and then you inhale gently and slowly, and the device will actuate with that gentle maneuver. You ask the patient to inhale over 3 to 4 seconds. So you may say, now, why is it not 5 to 7 seconds? And that's because of the sophisticated device engineering. The aerosol allows the gentle passing past the throat and better into the lungs. And then you have a breath hold pause, and then you close the device. So it's like a metered-dose inhaler, but easier, and it's far more better for the patient who cannot achieve those high flows through a dry powder inhaler device. I'm not going to go through this slide, but this is in the paper that we published in Respiratory Medicine 2023. It's a table that highlights the robustness studies of SynchroBreathe. So the first one is the triggering flow rate. The triggering flow rate, 30 liters per minute, 35 liters per minute. The second weight is the consistency in the delivery of the aerosol. The third one is the resilience to differences in temperature. And one key point, and we did the ERS India just a few weeks ago in Delhi and Hyderabad. Some of you will have been there, some of you may have seen it. And the point of humidity was raised. And you've got to be careful about humidity with dry powder inhaler devices. And I also say, do not keep your inhalers in the glove compartment box of the car, because the temperatures can reach up to 50 degrees, and that can affect the performance of the aerosol, be that a DPI or an MDI. And then there was a drop test, a physical test. In reality, some of the patients dropped these inhalers, they don't carry them properly, and there was resilience with the SynchroBreathe. So these were partly technical and regulatory aspects to look at the robustness in everyday use. So if we move on now, and this was a study that was published in 2019. It's often forgotten about, and Dr. Gogte was a senior author. The key point I want to show you is, look on the right-hand side, that first top graph, the blue arrows are pointing up. After 2 weeks of use of SynchroBreathe being trained, you can see more participants had less errors. So there was an intuitive learning process with this very straightforward breath-actuated metered-dose inhaler. The second point, look at the bottom graph in red, the red arrows go down. The average number of attempts to inhale correctly improved. There were less attempts to inhale correctly after 14 days. So again, this is a combination of, yes, it's a novel device. Yes, it's a new device. Will our patients be able to engage with it? Will they learn with it in real life? Will they actually be able to get the technique right? And this study clearly shows the answer is yes. And there is a variety of people throughout India who are involved in this study. So let's move on. We've talked about inhalation profiles across the globe in Netherlands and in Europe. What about inhalation profiles in India? So this was a nice study, and it was an old study presented at the APSR. It looked at the inhalation profiles in Indian patients with obstructive airways disease. The inject dial was used. This is shown on the top right. It's this device. I know some of you are aware of it, but some of you who are not, essentially it's an inspiratory flow meter. On the side of this device is red, orange, and green. It has a movable click on the front that has a icon that you decide which resistance of dry powder inhaler you are using or meter dose. You change the icon. There are 6 icons, and there's a leaflet that tells you to match the dry powder inhaler device with the icon. then you test your patient to inhale deeply and quickly. And if on the right-hand side, the arrow moves to the green area, then you know your patient can achieve this. So let's look at the data in nearly 200 patients with asthma, COPD, and importantly, children. What was found was that even severe COPD patients and young children could achieve a peak inspiratory flow rate of at least 35-40 liters per minute. So what's the key there? The key there is they are able to actuate the low inspiratory flow of SynchroBreathe. Why does SynchroBreathe have this low inspiratory flow? It's the inhaler engineering, it's the spring, it's the inhaler engine. So this is really important. Whereas those patients may not have enough inspiratory flow to generate from a dry powder inhaler device. So this is now Indian data. So let's move on. This is from NAPCON 2020. And the key point is there's low deposition in the throat. Why? Because it's a low inspiratory flow rate. It's a gentle trigger. And now the data clearly shows this. So this was formoterol and budesonide. You see the dark blue with the meter dose inhaler and the orange with the SynchroBreathe. And you can see that there was almost, gosh, a 10-20% reduction from the blue to the orange in throat deposition. And that's really important. Not because throat deposition is a worry for Candida. Yes, of course. But for me, throat deposition means stomach, means blood, means potential systemic delivery of steroid to the bloodstream via the throat. So I always worry when our patients complain to me about a hoarse voice or Candida that actually they are getting systemic exposure, and I change the device to find one that has reduced throat deposition, or I relook at the inhalation technique they're using. So conversely, what do we find? We find lung deposition increases. So this was a really nice study, 2019, again at the ERS, well, not again, sorry, this was at the ERS Congress. And what you see here is gamma scintigraphy. And you can see in orange, traditional PMDI, and SynchroBreathe now in red. And clearly, SynchroBreathe improved lung deposition. So this is intuitive. If you are decreasing your throat, you will have more aerosol to go into the lung. And the science, because the talk is about science, clearly shows you that this is happening, the science in the lung based on the science from the device. So let's now move on. In the final section, really is on the clinical data that has accumulated over the last 2 years in particular, but I'll be touching on some other previous studies as well. So let's talk about inhaler adherence and inhaler adherence within India, which is, believe it or not, the same across the globe. I was really interested at this ERS poster that was presented at 2025 last year, and it is concordant with the problems that we see across the globe in Latin America, in America, and also in Europe. So what was done by the team here? They looked at adherence to inhalers in asthma and COPD patients. So if you look at the methodology, over 700, nearly 800 patients in 23 sites in India. The adherence monitoring test was the TAI, Test of Adherence to Inhaler. It's a questionnaire and it's a validated questionnaire, so you can assess adherence. So what did they find in the results? 62% were asthma, 38% was COPD, and you can see on average, 1/3 had good adherence, 2/3 did not have good adherence. So if you look on the right-hand side, you've got the first graph, which is the ACT, the asthma control test in asthma, and then you've got the COPD assessment test in COPD on the right-hand side. So two different disease groups, but very telling. Look at the first graph. In asthma, clearly you can see poor adherence correlates with poor control. And on the right-hand side, you can see again that poor adherence, which is the furthest, correlates with a high impact, high COPD. So this was really nice data in a large cohort in 2 of our key chronic respiratory diseases to show that 1, at best 1/3 adhere, and 2, poor adherence is linked to poor outcomes. So let's move on and build on that data. And this was presented at NAPCON in 2025. So this was now where, okay, if we understand that we've got poor adherence, can that adherence be improved, or does it differ across the different types of inhaler devices? Now, this is a very busy slide, but really what I want to show you is the map of India that shows the variety of sites and regions that were involved. And the key point here is that they looked again at the asthma control test and the CAT, the COPD assessment test, and they looked at nearly 400 patients across 17 respiratory clinics. So this is complex, but I want to point you to the middle line and in blue adherence, and look at that graph. So across different devices, the DPI, you can see there's 76% adherence, the PMDI traditional one or with spacer 65, and the breath actuated PMDI 91. Now you may say, okay, the study is supported by CIPLA, it's going to show things are promoting the breath actuated. Well, CIPLA, as you know, has DPIs. You'll know the CIPALA, the multi-dose as well. It's got PMDIs. So actually, it's got all the devices. And really, this was trying to understand, does the science of the device correlate to an improvement for clinical benefit? And this study at NAPCON clearly shows that's the case. So what did they find? They found overall there was poor adherence to conclusions. On the bottom right, 50% were poorly adherent to inhalers, but there were differences between different devices. BA PMDIs, Synchrobreathe, had a better adherence. And critically, again, this study corroborated that if you improve the adherence, you can decrease exacerbation rates and decrease hospitalizations. You see that in the table there. You see that in the table, exacerbation rate, hospitalization rate on the right-hand side in white, comparing the BA, breath-actuated MDI, traditional MDI, MDI spacer, and the DPI. So patients who were adherent to the breath-actuated PMDI had lower exacerbations and hospitalizations. So this piece of data is critical in moving that science connection to the clinic further, in that the type of device now matters. So now that was secondary care. What about primary care? So this was presented at the ERS India Summit in 2026. And clearly, what did this survey do? So this was Sonia Dalal's work, and what they undertook was nearly 400 physicians from 25 states, and there were a variety of faculty involved. And clearly what they found was across the board that breath-actuated inhalers actually improved adherence. And when they were asked about its use in primary care, that actually they felt there was the inhaler engine, the science, the spring translated to a gentle flow that patients were able to activate, that reduced errors and reduced training. So what did this study do? It built on that usability study that was from a while back. It built on the perception that actually the science translates to a clinical patient benefit. And it built on the adherence data that you've seen from NAPCON and that you've seen previously on the inhaler study. So the difficulties, cost, and limited availability of the different molecules in the BAI were cited as the key barriers to wider BAI adoption. That might be something we can talk about in the fireside chat when we have Dr. Gogte, although I will be showing you a table that now shows a more extensive drug device combination with the Synchrobreathe. So in conclusion, primary factors governing physicians' preference included improvement in coordination, ease of use, training, and reduced errors. They were commonly prescribed for long-term maintenance therapy, particularly in those that were discharged on nebulizers, newly diagnosed patients in step-up, and there was better adherence and effectiveness in BAIs compared to MDIs and DPIs. So the data is accumulating, and that was recent data. So let's now move on to two key studies that were done, real-life studies. So this is the EMERGE study that was looked at the outcomes of formoterol budesonide through the Synchrobreathe in COPD patients. And so this was 12 weeks of treatment with Synchrobreathe in that combination. And really, let's look at the graphs on the right-hand side. Over 12 weeks, the CAT score improved in patients, 17.78 to 11.20. The right-hand side, Borg score, as an indication of dyspnea. What do our COPD patients complain about? They complain about dyspnea. the Borg score improved. Mightn't that be the case because this device now is able to effectively deliver the drugs, whereas previous devices were not able to do that? And so now we see the improvement in what matters to the patient, which is shortness of breath. And now you look at the graph there on the bottom, you have the 4 columns, you have very high, high, medium, low, and very low in terms of your proportion of patients with CAT score. And what you can see over time is that from baseline to week 12, the red bar decreases and the purple bar increases, the blue bar increases, and that's showing that more patients have more controlled CAT score over this 3-month treatment period. So that's really, again, nice data. And this was published in Drugs and Real World Outcome in 2025. So the key points, the study, the majority found Synchrony easy to use, but the key point is treatment was well tolerated. No serious adverse events were reported, and critically, there was an improvement in the Borg and the CAT score and the proportion in CAT. So now a second critical study, and that's in asthma, and this is the EVOLVE study. So the EVOLVE study, in this large cohort of nearly 500 patients with asthma who were treatment naive or uncontrolled due to poor inhaler technique, were actually then given the Synchrony device. And essentially, this was similar study design, 12 weeks, as we saw in the COPD. And what you can see there is this graph. So you see the graph, you see on the x-axis baseline, week 4, week 8, week 12, and what you can see is well controlled and the proportion of subjects who were well controlled with your ACQ-6 score, and you can see that's progressively increasing. So here they concluded that 3 months of treatment with salmeterol fluticasone through Synchrony was tolerated, and they actually improved in their level of control. So again, the importance of the device, because we may have tried previous combinations of these drugs and the patient didn't improve, and suddenly what we're doing is we're stepping the treatment up. We're adding another drug, we're adding maybe montelukast, we're adding another inhaler device. Maybe changing the device that is more efficient in reduced oropharyngeal, better lung deposition, science of the device improves the CAT, improves the ACQ. So, and I go back to this, and this comes back to real world usability now in the EMERGE study in COPD. And what you can clearly see there is the assessment at 4 weeks. And actually, in real life, in the real world setting, patients did feel things were better. My final 2 areas, 4 slides, are in the pediatric arena. And this is really interesting. It was presented at Respicon in 2023, and it's in the acute situation. So we've talked about real world setting, we've talked about secondary care, we've talked about stable patients or a little bit uncontrolled, here in the acute setting. So here, children over 7 and less than 15 with severe exacerbations, essentially, physician 7 to 15, physician diagnosed asthma, and what they were given was levosalbutamol through the Synchrobreathe, through Levolin, 4 puffs every 20 minutes for a period of 1 hour during a presentation of acute exacerbation of asthma. So if we now look at the graph and you look at the orange bar chart in the middle, you can see from baseline up to 60 minutes that actually their pulmonary score, there was an improvement in respiratory rate, wheezing, and chest retractions as a composite pulmonary score. And 90% of patients could trigger the Synchrobreathe even during an acute attack. So that's important. In an acute attack, when the respiratory rate is high, when patients don't have the time to generate the inspiratory flow that's required from a dry powder inhaler device, or indeed don't have the ability to put a spacer onto a metered-dose inhaler, here you've got the low trigger flow, you've got a breath actuated device, the low trigger flow is activated, and in the acute setting, it was clearly shown. And this links into very nicely into the peak inspiratory flow data in the Indian population, where even in the severe situation, they can actuate the Synchrobreathe device, which has a low inhalation flow. So this is data now in real life in acute asthma in children. And then finally, in special needs. So this was a small case series of 3 patients, 10 to 13, but it was in children with attention deficit disorder who can struggle using the inhaler device and have difficulties in coordination. So what I like about this study is we often hear this data from drug companies that our device, the usability is better, and we think, yes, of course you're going to say that. But here, using children who truly have a problem in the technique of the device, what was found? That there was an improvement in these patients. So often they required to take 6 to 10 breaths through a spacer. They found there was an improvement in asthma control, and they hypothesized that the technical ease of using a BAI overcome the coordination difficulties in these special needs children. And there, the third bullet point summarizes the low inspiratory flow, the low throat deposition, the high lung deposition, and this the science of the device in the inspiratory flow and its improvement in coordination and cooperation. So that's the final slide. You now have budesonide, glycopyrronium formoterol, budesonide formoterol, budesonide, glycopyrronium formoterol, and probably the salbutamol as well. I think it's possibly missing from this table, maybe in Synchrony as well, but we'll be updated on that. So in summary, the historical perspective we've seen from 2000 BC in India all the way to a breath-actuated device you have with a variety of drugs. So you're in a really good position, I think. The inhaler choice, I've gone through the various inhalers, how we choose them. Remember peak inspiratory flow. Remember not just adherence compliance, the technique is important. Remember some patients do not have that inspiratory muscle strength to activate DPIs, even though we think DPIs may be simple. The Synchrobreathe breath-actuated inhaler, well, what will I say that I haven't said already in terms of giving you the science so that you can decide that that next patient you see, is there a consideration in using the device to improve my outcomes, in that patient with asthma, in that patient with COPD, that we've seen with the eMERGE and the eVOLVE study, with acute asthma, with special needs, that actually then we finally see that the breath-actuated inhaler has a position in airways disease. So on that note, thank you very much for your attention. I know I've gone a little bit over time, but I really wanted to consolidate on this before we go into the fireside chat, and I'll hand you back to the team in the studio.
Thank you. Thank you so much, Professor Usmani. I think that was a very wonderful talk, delivered beautifully, emphasizing not only that a drug is important to manage your OAD patients, but the device is equally important, particularly with regards to its ability, the patient's ability to take the device, because that will impact your overall adherence and the side effects also, which have an overall impact on the patient's COPD or asthma management. I think very importantly that you brought out was the importance of your peak inspiratory flow. A huge chunk of our OAD patients, particularly the COPD patients, have a suboptimal peak inspiratory flow, and that can impact your overall prognosis, particularly if the device which is selected is not correct. Unfortunately, today, even in the world of digitization and where we are heading towards innovation, in India, we lack an objective assessment of peak inspiratory flow rates. I think we'll discuss that when we head towards a panel discussion. But we do a lot of subjective assessment of peak inspiratory flow rates in our country. Talking about digitization, we have a lot of smart inhalers and app-based programs, etc., to assess patient technique and adherence. So the next session, we'll be talking about digitization and innovation, particularly in the inhalers, in the therapy of inhalation. So can we have the CV slide for that, please? Yeah. So with immense pleasure, I would like to call upon Dr. Usmani as well as Dr. Gokte. Dr. Gokte is the Global Chief Medical Officer at Cipla. He's been with Cipla over the last 3 decades, and he looks after the global medical affairs, clinical development for India, and the global pharmacovigilance of Cipla. He comes from Grant Medical College and JJ Group of Hospitals in Mumbai, and he's done his MD in pharmacology from GS Medical College in Mumbai. Dr. Gokte has been involved in the development and introduction of several drugs in various therapeutic fields, with particular and immense work done on HIV, AIDS, infectious diseases, and he has a deep love and interest towards respiratory medicine. He's worked on multiple clinical trials, and he was very much importantly involved in setting up the Chest Research Foundation, which is an independent research center which was running in India for approximately 2 decades. He's been a part of various national and international conferences where he's delivered lectures and has had multiple publications to his name. He was a member of the Association of Physicians of India guidelines in 2005 on antiretroviral therapy, again reiterating his particular love towards HIV and AIDS. And he's also participated in various research methodology workshops with academic institutes. So we'll be having a fireside chat with him and Professor Usmani to talk about the future of inhalation therapy, where it is headed, and what do we expect to see. Over to you, Dr. Gokte and Professor Usmani.
So thank you, Rushika, very much. And I hope everyone can hear me clearly. Should probably we have Umar also in the screen. Yep. To the tech team. I don't know what the audience can see. To the tech team, can you bring on Dr. Umar on the screen? Because
Yes, Dr.
I'm unable to
Gokte.
see him.
He's there on screen. We can see him.
Okay, because I'm not able to see him, that's why. Okay. So, Umar, that was a fantastic talk, I think, on breath-actuated inhalers. I'm sure everybody got a gist of all the data that you presented. But let me ask you 2 or 3 fundamental questions. But before I jump into questions, I want to ask you something which may be out of the script. You're probably one of the few or rare pulmonologists who also did a doctorate in aerosol science. And what is it that drew you to doing a doctorate in aerosol science?
So I always loved maths and physics at school, and actually for my for entrance to medical school, I did maths, physics, and chemistry as my A levels, and I didn't do biology. But there's always a requirement of biology, so I had to really mad dash and do biology in 6 months. So I've always had an interest in maths and physics, I think, JD. And then going back to basics, and yes, the world is a lot on genetics, the world is on molecular biology, but I really had an interest, I think, in pharmacology and physiology, and that's been continued. And again, I was in the department of Peter Barnes, where I did the pharmacology, I did molecular biology of how different drugs work on the glucocorticoid receptor, on the epithelium. I did work on cough in animal models in patients, and I also did this work. And it was this work that really I wanted to submit for my PhD. So it was a very much an interest in the principal fields of maths and physics, I think, that drove me into this area.
Fascinating. I think aerosol science can be really fascinating. So if we were to look a little into the future, what we've heard a lot and what you presented is historical perspective, what's currently happening in the field of inhaler devices. But if you try to take a peek into the future, could you hazard a guess as to what's going to happen in the next 5-7 years? Do you think there'll be an emphasis on new drugs, new combinations, new inhaler devices? What do you think, where are we headed?
So I think JTP presented some of this as well as ERS India. It's not 5-6 years, it's happening now. So actually, there are really exciting new drugs that are being delivered by the inhaled route, not just to treat the lungs, but outside the lungs. So if I can give you an example, for lungs now, there is inhaled trials going on for interstitial lung disease, for IPF. There are inhaled trials going on for alpha-1 antitrypsin. There is one drug that's licensed in the US, but there are repurposed drugs now. And in the world of asthma biologics, where we're giving our asthma biologics via the intravenous or subcutaneous route or IM route, now inhaled biologics are in clinical trials now for the treatment of asthma. So there is a lot of bronchiectasis inhaled drug. I know we've had the DPPI, the tablet just licensed globally, but inhaled drug bronchiectasis, and not just antibiotics, but actually looking at disease mechanisms. So it's now, not just 5-6 years, companies are investing in devices, in drugs to target the lungs. Why? Because they're reaching the site of action. And why? Because they're improving the therapeutic index. And that's the key thing. It's a therapeutic index. But also, it's really exciting times because the lungs are now being used as a portal for entry into treating diseases outside the lungs. So if I give you an example, there is a trial now that's starting in Africa where inhaled oxytocin is being given. So we all know that oxytocin is given to at the third stage of labor after delivery of the placenta to contract the placenta and stop bleeding. Why? Because maternal hemorrhage is the key cause of death globally. So oxytocin or synthometrin requires a fridge or a freezer, which requires electricity, which aren't available in many villages. And so now inhaled oxytocin has been delivered via a powder device that is a single use, that is very gentle inspiration, that doesn't require electricity, that can be kept in very remote villages and given to women. So after delivery. There's work on diabetes now, so diabetes as well. 15 years ago, there's a lot of work. 20 years ago, it then was stopped, and now we've had the first licensing of inhaled insulin in the States. So there's a lot of innovation, engineering, and science that maybe clinicians, I think, Jaydeep, don't appreciate.
Yeah, fascinating. I think where the world is going, we're using lung not just for lung diseases, but also for others. But going back to asthma and COPD, do you think we are maxing out with dual, triple combinations, or do you think there are opportunities or any unmet needs for chronic airway disease? Because we still see asthma control remains relatively poor. We still see that COPD patients, despite where we have gone, continue to exacerbate. So do you think there's anything coming on top of just in this era of asthma COPD that we see some unmet needs?
Yeah, so I think two areas. One, and another passion of mine is that we need to treat the whole airway tree. So I think some of our devices are just treating the top part, which is very good, but they don't treat the whole airway tree. And we now know from immunopathology in COPD, immunopathology in asthma, immunopathology in bronchiectasis, in ILD, that we need to treat the whole airway tree. So there is a gap for innovation in devices being able to treat the whole airway tree. And how can you do that? Yes, you can use particle size, but also a slow inspiratory maneuver, a slow breath. Because if you slow the breath down and you have a slow flow, that drug will bypass the throat, go into the lungs, and potentially travel deeper into the lungs, as you see with Synchrobreathe, and you see low throat, but also as you see with particle size modulation. And then the other point is are there new drugs, are there new entities that can be added on? So a triple potentially becomes a quadruple. You've got the PDE3, PDE4 inhibitor now that is combination therapy that's now licensed in the United States by nebulized delivery. The question is, should you add that onto a steroid, onto a LAMA, onto a LABA? What will be the role of PDE3, PDE4? Will it stop people progressing? What about using an inhaled macrolide? We know macrolides are used for biologics in asthma, before people are given, and they have a very good remission rate as well, and in COPD, so inhaled macrolides. Where is the role for that? And so I think there is room in the drug field and in the device field still in asthma and COPD.
Oh, interesting. I think so you'd be glad to know, and also the audience listening, that the inhaled PD3, PD4 inhibitors should be starting a phase 3 clinical trial in India sometime in the next 2 to 3 months. And if all goes well, it could even be in the market in the next 12 to 15 months in India. So we will have a drug with a new mechanism of action, at least for COPD. So you use the word engage a lot when you talked about patients and their devices. We engage a lot so much with our phones. We wish patients would engage equally well with their inhaler devices for their asthma COPD. But there is now integration over to attempts being made to integrate your phone with the inhaler device. So do you think this so-called digital therapeutics that people have talked about, and I know you've been working in this area, you had some grants also to study this, whether you put a little thing on top or you have a jacket where you can put your inhaler in, link to your phone to improve adherence or to tell you about your technique. Is this really catching on? Do you think patients feel the need for it? Do physicians perceive the need for this? What's your opinion on this?
Yeah, so I think some of the very first studies were published by Amy Chan, who's a pharmacist in New Zealand in 2015. And this was in the pediatric population and then evolved into the adult. And the key point is yes, we have a lot of technology. Yes, there's a lot of digital innovation, is showing that it makes a difference to the patient in real life, showing it makes so the digital innovation may improve the technique, it may improve the adherence, does that translate to an improvement in compliance? And actually that data is now coming through. So funnily enough, one of the key studies was done during the pandemic in COVID by a group in the United States, where a group of their patients already had a digital inhaler. And because patients did not want to be admitted into hospital because of fear of dying from COVID, they were adhering better. And in adhering better, their control improved. So, so the work on digital is going on to allow us to, first of all, really see if there is a real world benefit, but as you say, trying to improve engagement. The thing is, the problem with digital is people put too much into that digital app. They put the weather index, they put the pollution count, they put this note, that note, and patients don't want that. So now people are having patients on board in developing the app that is targeted to their needs with asthma and COPD.
Interesting. So involving the patients in developing the apps and not just the engineers or the doctors who want to do it. But I think
No,
interesting.
JD.
So,
And that's called UCD, user-centered design. So people have
user-centered design.
realized the mistakes of engineers being involved or just doctors thinking what patients need, but actually patients saying, we don't need this, this is what we need.
Keep it simple. So do you see any barriers as the data comes out to the adoption of these technologies by either of patients or physicians? And more than that, because this will cost a little more, do you think there is a cost effectiveness angle that people would be willing to pay a little more for these interventions?
Yeah, so here in the UK, as you know, a lot of our prescribing and a lot of our licensing is directed by health economic evaluation.
Right.
So part of the need for the digital therapeutic inhaler is to show that there is a health economic benefit. Now, it varies in different countries. It's probably more stringent in the UK. In other places, it's less stringent. Less stringent doesn't mean to say that it's not right. I mean, it allows the opportunity for people to understand the economic evaluation in the context of benefit to patient. So cost for sure, time of who's going to do this. So in the UK, the role of the pharmacist now has been increased so that they will be managing digital diabetes, digital possibly inhalers if they come, digital blood pressure. So they have become, as the group that will be part of a multidisciplinary team with the physician in managing the digital. Because otherwise, who will do this? I mean, we're lucky.
That's
We
right.
probably have 12 minutes with a patient in the UK. You only have 3 minutes with a patient in India. So you have to find out why their asthma is bad. Is it the pollution? Is it allergy? Is there something else going on? Is it anxiety? Are they on the right drugs? Are they adhering? Are they complying? Do they have the right technique? So time is required to spend on patients to get the technique right, plus or minus a digital intervention.
Fantastic. I think we can really chat on this for much longer, but I'm going to stop here because I know we'll run out of time otherwise for the panel discussion. So, Mar, thank you very much for the brilliant talk. We thoroughly enjoyed our discussion, and I'm going to hand this back to our host. So, to the audience, thank you very much, and we shall move on to the panel discussion. Thank you.
Thank you. Thank you so much, Dr. Gupte. Thank you, Professor Usmani. I think that was really interesting to know where we are headed in the future towards inhalation, and need not restrict it to respiratory, but to even other systemic diseases. So that's really interesting to know. I think in the interest of time, let's move ahead to the panel discussion. And we have an eminent faculty today who is going to join us for the panel discussion. We start with Dr. Sanjeev Nair. I think most of the students and the pulmonology faculty will know Dr. Sanjeev Nair across the country. He is the professor at the Department of Pulmonary Medicine, coming from Government Medical College, Trivandrum. He is the chairman of the Zonal Task Force for Medical Colleges in NTEP from the South Zone 2. He is also the subject expert and the National Technical Expert in the National Technical Expert Group, NTEP. He is a member of the National Technical Expert Group for COPD. He is a member of the GBD India for the Chronic Respiratory Diseases Group. He's been the chairman, State Latent TB Infection Working Committee from the Kerala State. He's an expert member for the Difficult to Treat TB Clinic of the Central TB Division. He is the state coordinator for the State Difficult to Treat TB Clinic from Kerala. He is the consultant for the development and implementation of the Kerala Government State COPD Prevention and Control Group Program, SWAS, and he's also been the President, Academic of Pulmonary and Critical Care Medicine, NTEP STF Chair, Kerala, WHO RNTCP Consultant, Tamil Nadu and Kerala. So a warm welcome to you, Dr. Nair, and thank you for being here today for today's event. We have Dr. Anshum Aneja. I think many of us know her. She's a young pulmonologist coming up at Gurugram. She's the visiting consultant at CK Birla Virizon Hospital, Med Harbour Hospital, Gurugram. Her main areas of interest are asthma, oscillometry, which is the upcoming and probably the future of obstructive airway disease diagnosis. She also shows a keen interest in the circadian rhythm of sleep disorders, pediatric sleep, sleep-related breathing disorders, patient education, and counseling. She is very much interested and very apt for today's world in digitization, and hence she is the academic content creator and educator on YouTube. She is a member of the ERS and lifetime member of the Indian Chess Society. A warm welcome to you, Dr. Anshum.
Thank you.
Dr. Kalpesh Panchal. He's from Ahmedabad. He's a consultant interventional pulmonologist at the Swastik Lungs Care and Allergy Clinic. He has got a gold medal in MD Pulmonary Medicine, and he's got numerous awards, including the first prize in the poster presentation at Allergicon 2020 and at NAPCon 2023. He's involved in a lot of clinical trials and real-world studies also. So a warm welcome to you, Dr. Kalpesh Panchal. And Dr. Soumya Nagarajan. She's the consultant pediatrician, allergist, and immunologist coming from the city of Bengaluru. She's the secretary, IAP, National Allergy and Applied Immunology, Chapter 2026. She has various publications in national and international journals and has been a faculty at various conferences, both national and international. She's the co-author for National Guidelines on Air Pollution and Asthma and Cow's Milk Allergy Guidelines, something very interesting, and has been the editor for the comprehensive textbook of allergy and Allergy 360. So a warm welcome to you, Dr. Soumya Nagarajan, too. So we'll begin without much delay. I think taking a cue from where we left the fireside chat on talking about challenges, where we are talking one side on challenges in the innovation portfolio or where we are headed in the future of digitization, etc. We still face a lot of challenges when we are using our PMDIs, DPIs, breath-actuated inhalers in today's practice also. So I wanted to understand, we'll start with you, Dr. Sanjeev Nair. In your routine practice, what are the most common challenges that you face in your asthma as well as COPD patients while we are giving them or prescribing them PMDIs or DPIs?
Thank you, Rushika. Thank you for the invitation. It was an excellent talk by Dr. Usmani, and we were listening with great interest on him taking us from the history going like 3,000 years back all the way down to what is happening currently. So looking at the short-term experience over the last 20, 30 years with inhalers in my practice, in my part of the world, what has changed for good is, maybe in the past, MDIs and DPIs were not really accepted by patients. The reaction from patients would be almost like as if you're giving them the prognosis of a very grave disease when you tell them that you're starting an inhaler. But there is much more acceptance in India, and at least in my part of the world, with inhalers. And when you talk to patients on starting inhalers, they're okay with it. The other change which has come in is, maybe like 20 years back in my practice, people would be on oral drugs, and it's only when they come to my level that inhalers would be started. Today, inhalers are being started at general practitioner level, physician level, and most of the patients with obstructive airway disease coming to my level are already on inhalers. But sadly, there are two things which are lacking. The first one is very poor inhaler technique. I think we published about 20 years back on inhaler technique, and sadly, there hasn't been so much of an improvement despite all the knowledge and all the dissemination that we have done on use of inhalers, inhaler technique, and all that. Sadly, a significant proportion of patients use inhalers poorly. I totally agree with Dr. Usmani that, with the dry powder inhalers, probably, in fact, in my practice, even a higher proportion of patients than the 50% that he mentioned actually use it poorly. I might be biased in the way that maybe the ones who are using their DPI well may not be coming to my level. Maybe they're just staying at GP level because they are doing well. But the ones who come to my level, we find it difficult. And even with the meter dose inhalers, without spacer, the technique is obviously. The other sad thing that we see at our level is poor adherence. Despite all the efforts, despite all of us, telling them and all, they have all kind of innovative excuses
Right.
for not using an inhaler. I think that is a problem all over India. We have been seeing that in presentations all over, and I think that is a major issue to be addressed. You have discussed some of the ways of how to address that, but I'll not go into details of that. In short, this is what we have right now.
Right. I think you very rightly said, sir, that, the technique of the patients many a times is going wrong. And, despite the teach back trainings, etc., which is imparted to the patients, they still go wrong again and again. And probably that could also be there could also be a factor of the recall memory. Patients, we teach them the inhaler at our visit, and then they go back and they forget how to use the steps, or they forget the steps of using the inhaler. And hence they, over the period of time, they still commit errors while using their PMDIs and DPIs. Dr. Panchal, sir, would you like to add something from your experience with DPIs and PMDIs?
So first of all, thank you, Sipla, and my distinguished faculties. What I have observed in my short experience of last 10 years, I have worked with corporate hospitals also, and I am running my own clinic. So apart from the medical stores or pharmacies attached to the respiratory clinics, majority of our pharmacists and pharmacist assistants are not able to explain the inhalation therapies to the patients. So despite of having almost all combinations are available even in breath actuated inhalers or even in PMDIs and DPIs, still our patients of obstructive airway disease are facing poorly controlled disease, recurrent exacerbations, and wrong techniques. So this is the critical gap that I have observed, that the patients, those who have either ordered or purchased their medicines from the pharmacies, those who have not adequately trained staff in their stores. So this is a critical gap that I have observed. And second thing is the time that in busy OPDs, in particularly in high volume centers, where doctor cannot spend an adequate time with the patient. So there is a three important step which I have done in my practice. At first, I explain the inhalation technique in front of the patient. Second, my respiratory therapist or PFT technician. And third is the pharmacist. So at least 15 to 20 minutes we need to spare with the patient for adequate teaching of whatever kind of inhalation therapy which we prescribe, either DPI, PMDI, or breath actuated inhalers. And yes, the important part we need to take care whenever we prescribe the PMDIs, like actuation, inhalation coordination, and for DPI is peak inspiratory flow rate. These two things are important.
I think so. You've very rightly brought out the point of the pharmacist, the role of pharmacists. It's a very critical role because, as I understand, what is routine clinical practice in the Indian healthcare setting is that either the doctor teaches the patient the technique, or he asks the nurse in his clinic or whoever the PFT technician is to teach the technique to the patient, or he asks the patient to get it back from the pharmacy and show it to whoever is the trained person. But many a times people don't have this kind of a support in their clinical practice, and there probably the gap is huge where pharmacists could play a very important role. And correct me if I'm wrong, Professor Osmani, this is a practice globally that pharmacists are trained on inhalation technique also. So that is, I think, a very critical gap which is there in our country. And I think kudos to you for, training your pharmacist at least to try to bridge this gap in our country. Coming to you, Dr.
Just
Nagaraj.
to add to that, just
Yes, sir,
one
please.
point. I think India, we have to also look at like Panchal was saying on the how busy doctors are, 200, 300
Yes.
patients often coming to a practice. I think pharmacists also have the same problem. You have a window system where maybe you have 100 people standing in a queue, there are crowded places. There is some amount of stigma with using an inhaler. So that may not really be the ideal scenario where you train also. And the other point that I wanted to make is that sadly, you still see patients whom no one has trained. Neither a
Yes.
pharmacist nor a doctor has trained, and they come with poor inhaler techniques. So I think this is something that needs to be urgently addressed because, and I also believe that once a patient gets an inhaler wrong, it is more difficult to get it right rather than a new patient who has not been ever trained.
Because they're accustomed to that technique. So it's like on a spinal level, they're just doing the same thing again and again, despite teaching them, the correct technique repeatedly. Very valid point, sir. Coming to you, Dr. Nagarajan, we're all adult pulmonologists over here. Do you have a different perspective from the pediatric population? What are the most common errors that they face? Is it something different from what we are seeing in adult OAD patients, or are more or less the challenges are similar? what is your point of view for pediatric population and the errors that they make?
Thank you. At the utmost, I would like to thank the CIPLA team for having me over in an extinguished adult pulmonology panel discussion. I think in the pediatrics, where Dr. Usmani was talking about, and that was our study in the breath actuated inhalers we were talking about. I think the common inhaler errors in pediatrics are a little unique as compared to adults. I think in pediatrics, we feel that they frequently fail to hold their breath for 5 to 10 seconds, which is mandatorily required, we tell after inhalation, especially younger children, which has an impact on the deposition of the drug in the lungs and increases mainly the oropharyngeal deposition. Sometimes, I think parents also, I think it may be an error in what we have thought. They may take a deep breath fast. So it may be they may tend to inhale too rapidly or too shallow at times. I think it, especially with this, with very true for meter dose inhalers, leading on to again more drug deposition in the mouth and the throat. And a unique population is the adolescent. They're not exactly pediatrics, they're not exactly adults. But I think with the stigma of the spacer, they feel it hampers, especially if they have to take it in the school or in the college. They skip spacer usage despite we recommend that it is guidelines and it is appropriate for the drug deposition. This is one thing in this adolescents we see that they skip using inhalers, which further again increases local deposition and lowers effective dose. I think um, these are the more common uh, errors we see in the pediatric population. And I think that's where the breath actuated inhalers come into role. And I think these can address some of the challenges we see in the pediatric population because, again, because it is breath actuated and it can eliminate the need for this precise coordination and activation. I think whoever has been having issues with using the traditional PMDIs with inhalers, if they actuate, I think we have seen good results with the breath actuated inhalers in this population.
Right. So just to add one little thought to that, Dr. Nagarajan, in the pediatric population, you have a lot of importance of caregivers, right? The parents, because they are predominantly involved in giving the drugs to the children. So do you see any particular challenge when caretakers are involved in giving the drugs to the patient?
I think again the stigma of using inhalers or with the spacers. The issue concern is this lifelong? Do we need to use inhalers forever? Does this lead on to addiction? Does it hamper growth? And I think sometimes it's the caregiver bias as well. The way we effectively teach the device demonstration or take back demo back from the caregivers. Sometimes if there is a lack of lacunae or the stigma or the bias from the caregivers, I think that also hampers in the pediatric drug device, the inhalation technique as well.
Inhalation technique, yeah. I think that is very important because they are very much actively involved in their children's asthma management. Right.
Can I add something to it? Yeah.
Yes, Dr. Ranjan,
Yeah.
please go ahead.
So I think in contrast to adult population, what I've seen is for the kids who come to me is that parents actually prefer nebulization in their child over an inhaler a lot of times because they feel that nebulization would be more of a transient measure and they're kind of used to having given it when they were infants also for a bronchitis and also so they feel maybe this is more transient and it will wear off, but once you give them the inhaler that would just not wear off. And there we have to again keep telling them, you're spending so much time early in the morning for the nebulization and you're getting an equivalent dose effect with an inhaler. So please, go for the device rather than a nebulizer when your child doesn't really need. So there's a kind of a contrast there also in the beliefs of the parents a lot of times that they don't want the inhaler, but they're okay with a short-term nebulization if that be it.
I think that's interesting, but very surprising also because if you see, if you need to make a child sit for 5 to 10 odd minutes to take the nebulization, it's very difficult to make children sit for that long time. So it's interesting, definitely, I mean, we don't know what goes around with children, definitely, no doubt.
Sure.
Okay. So moving ahead to the segment of acute exacerbations, whenever we talk about inhalers, inhalers, techniques, etc., we always talk about maintenance therapy, how are patients taking it on their routine OPD basis. But acute exacerbations also require a lot of, appropriate drug selection, appropriate device selection, etc. Talking about the drugs in the acute exacerbation section, how do you really select about, go about selecting which is the right short-acting drug? How do you give it through a particular device, etc.? I mean, would you prefer a PMDI or a breath-actuated inhaler or a nebulizer when the patient is coming with an acute exacerbation of either asthma or COPD? What are your thoughts on that? We'll start with Professor Osmani on that.
Really, we've got these 4 devices, and the key is the patient able to engage with that device? So you were talking about maybe the in-check dial isn't available or peak inspiratory flow. So sometimes a simple technique that I use if a patient is to be put on a DPI is I ask them in the clinic in 10 seconds, can you take and show me a really deep and hard breath and then hold it for 3 seconds? And I'm looking at the scalene muscles, the intercostal, and the diaphragm. If the diaphragm rises and is held for 3 seconds, if the intercostals are depressed for 3 seconds, if the scalene are tight for 3 seconds, then I have a surrogate marker that maybe they can generate the high inspiratory flow, and I'll use a DPI. The other approach is MDI. I will always tell them slowly and gently over 7 seconds. And it's a light bulb movement, because up until that point, they've been told you've got to actuate, you've got to inhale, you've got to do a breath hold pause all at once. So the psychology is overwhelming. And when you give them that comfort zone saying you have 7 seconds to inhale, it's a really gentle approach, then a lot of patients are able to use an MDI. Spacer, obviously, for the elderly, spacer for the children as well. And then the breath actuated. You're lucky you have the breath actuated. We don't have the breath actuated in all these devices. We used to have 1 or 2. And they aren't there not because they weren't good, but because the company's changed hands. So you're lucky to have this, to try this. And then the nebulizer, I tend to use nebulizers not that much, actually, in my patients. So the approach is just to engage with the right device for the right patient.
Okay. So when the patient is coming, with a moderate to severe exacerbation, I think your DPIs would be a little difficult to go ahead with, right? So you would probably go ahead with a PMDI or a breath-actuated inhaler. So do the principles which you spoke about apply to this category of patients also with moderate to severe exacerbations?
In moderate to severe exacerbations, then I would tend to use a patient with an MDI and a spacer and not a DPI, because in an exacerbation, the respiratory rate is really breathing very, very fast. They don't have the time to generate that strength. And if I look to all the national guidelines across the world, and none of them say in an acute exacerbation, use a DPI. They all say PMDI and spacer or nebulizer. So the interesting data that I really like about the pediatric acute asthma is that the breath actuated was able to be used. I'm not saying it's because it's a Cipla or anything. From a scientific perspective, maybe the inspiratory flow is low, and the trigger, and actually a breath actuated may be the advantage device instead of a PMDI plus spacer.
Okay, noted. Dr. Panchal, would you like to add something to that?
Yes, regarding the difference between the asthma and COPD, what in our India, generally our asthmatic patients are mainly on the DPIs, and during the acute exacerbations, many of our patients, we generally advise to take the same inhaler whenever you feel mild to moderate exacerbations. But in the case of COPD, where the patient have a very low peak inspiratory flow rate during moderate to severe exacerbations, so the challenge which we face that different combinations of inhaler in one patient, and to teach the patients, suppose our patient is already on DPI and they don't know how to use the PMDI or PMDI with spacer or breath actuated inhalers. So during acute exacerbation, it is very difficult for them to take the medicine, because many a times our patients doesn't carry this inhalers along with their in routine work. So and if we prescribe the any kind of PMDI or breath actuated inhalers, and if patient doesn't use it in last more than 3 weeks, then at the time of acute exacerbations we need to prime it, and we need to recall the same technique, and that might patient may get a wrong technique and wrong actuations, wrong coordinations. So during the acute exacerbation, I prefer in my asthma patient to use the same inhaler, smart therapy, same inhaler for controller, same inhaler for reliever. In my COPD patients, I generally teach my patients how to use PMDI in exacerbations or breath actuated inhalers.
Okay. So as I understand, you said that if the patient is taking one particular device with which he's comfortable with, you would prefer to use that same device when the patient goes into a mild exacerbation, correct? So if a
Yes.
patient is taking a PMDI, he continues to use the PMDI during an exacerbation. And if the patient has a BAI with which he's comfortable using it, you would prefer to continue the BAI when the patient is going into an exacerbation. I think very valid point, so that the patient's technique is not wrong. So if the technique is not wrong, then the benefit is much better. The efficacy of the drug and the device is much, much better. Anyone would like to add something over here? Dr. Sanjeev Nair?
Nothing.
All right. So moving ahead, we spoke about exacerbations. How do you manage the patients during an exacerbation? But if you look at all the guideline recommendations are very simple and straightforward. Once the patient is recovering from an exacerbation, if the patient has been on a nebulizer during an exacerbation, as soon as the patient is comfortable and able to switch to a particular inhaler device, the patient should be switched to a particular inhaler device, whatever the patient is comfortable using. Dr. Anshu Maneja, asking you this particular question. In order to ensure that the patient smoothly transits from a nebulizer during an acute exacerbation to an XYZ device, be it a DPI or a PMDI or a breath-actuated inhaler post an acute exacerbation, what would be the steps or the recommendations that you would look at, would advise any of the healthcare practitioners across the country or likewise to patients to ensure a smooth transition to a particular device?
Yeah, so I think again it depends on how severe the exacerbation was. Was this patient hospitalized in a ward setting, or was he in an ICU setting? Was he ventilated and all of that? So if I look at the severe exacerbations, as you would also agree, here the switch is a little more difficult. And many of these patients were in such a state that they may not have a good inspiratory flow. They may not be so confident. They may be too weak to handle an inhaler on by themselves. So I think that subset, and it's not a very big subset of patients, but that subset of patients, they would often go back home on nebulization only to be switched at a slightly later date on a follow-up. Once you know that the patient is now doing well and maintaining well, there's no V's now and has settled, the oxygenation is good. But the majority of the other patients who have a mild to moderate exacerbation who are in a ward, I would suggest, and what I do is usually to give them a 24-hour kind of a period in the hospital before they are discharged, where I make them comfortable with the inhaler, with the device that I've chosen alongside, and to monitor that there's no rebound effect. So something that we can practice is that start giving the inhale device earlier if he was on a nebulization, and to monitor that and make sure the patient understands how to take it. And again, the criteria for choosing the device would again be the same, the inspiratory flow rate measurement, and to see how well the patient is coping. So that is the advice for all doctors across there, because the switch has to be made, and to make that switch, the earlier we kind of sensitize the patient, the better it is. And under our observation, with the first dose being given right in front of us, and then the switch can be done.
Okay. So the correct timing.
So I think most guidelines and mostly in our practice, what we do agree is that the oxygenation has to be good. The patient should not have a brittle spasm, and he should not be on IV medication. And at that time, we can switch him to a inhaled device.
Okay. So the crucial point of timing, training of the patient under observation, and to ensure that he takes the inhaler, whichever device he is taking, correctly while he is in the hospital before sending him back home. I think that is a very important and valid point. Professor Usmani, do you do similarly at your practice in London? Do you follow a similar protocol?
In terms of Dr. Shah?
In terms of transitioning the patient from an XYZ device at the time of discharge when the
Having
patient
been on
is
a
coming for an acute
nebulizer.
exacerbation. Right.
Yeah, I mean, so at the point of discharge, they are seen by a member of the multidisciplinary team, a pharmacist, a nurse. We're lucky to have this, to see whether we transition them to a PMDI spacer or a soft mist inhaler. Particularly, they're recovering from an acute exacerbation of COPD or an acute exacerbation of asthma. We tend not to use DPIs because the respiratory muscles are relatively weak, and DPIs require the respiratory muscles to activate the device. So in the discharge period, we'd be using devices where the device does the work. I use this term. The device does the work. Nebulizer does the work. MDI does the work. MDI spacer does the work, not the patient. The patient, DPI. The patient's lungs need to do the work to get therapeutic benefit. And what we have seen, there was a study in Singapore, and what they found in Singapore, on the day of discharge, half were given a nebulizer, half were given a DPI, and there were higher readmission rates for DPI.
Right. With the
And
DPI.
why? Because they didn't have the inspiratory muscle strength at the point of discharge when their muscles are still recovering. It doesn't matter if it's a pneumonia or an allergy or a virus or whatever. The muscles are weak. The respiratory rate has been stressed. It's high. So I don't give DPIs at all on discharge. And then I reassess them at clinic in 4 weeks or 6 weeks to decide what is their stable device of choice. So, so that's what we tend to use. Although I have to say again, we use nebulizers slightly less in the UK.
Yes, fair. Point taken. Now, shifting gears a little bit more towards PRISM and PRESEO. Yes, Dr. Nair, please go ahead.
I just wanted to ask Dr. Usmani a question because of curiosity. In India, we often have the freedom to do what we want. You know, we are allowed to move away from guidelines. So we often see that, particularly the patients with frequent exacerbation, they take a nebulizer home. And there is a practice also among physicians to allow them to use a nebulizer. So how often do your patients actually, after a severe exacerbation, go home on a nebulizer?
Less than 5%. So, so the nebulizer, why has the nebulizer gained so much fan base amongst patients? Because it's large, it's a machine, it makes noise, and something's happening. But scientifically, only 5% of the drug reaches the lungs. 5%. Whereas if you are able to train an MDI spacer or a breath actuated or DPI, you will achieve 40% deposition in the lung and low deposition in the throat. So it's this whole thing that it's like, a tablet is better. Like you were saying, it was really interesting what you were saying, Sanjeev, about, the tablets and how things have moved and how your practice is a specialist and you may not see the problems in primary care. This thing that this tablet is the answer to everything. I mean, or the nebulizer is the answer to everything. So the science shows only 5%. And there's a very interesting study, Sanjeev, that's we're in the process of doing and others are doing, is in the acute situation, suddenly the patient comes to the ER, they're put on a nebulizer, very high dose of salbutamol, and it goes to the systemic circulation, 95% of it. And that may be triggering arrhythmias in COPD patients who already have a cardiovascular comorbidity. So we're now looking to see, comparing this group to a PMDI spacer, with respect to the adverse systemic burden of a beta agonist in an already heightened adrenaline situation of an acute admission in the ER with possibly an underlying cardiovascular comorbidity, maybe tipping patients into the HDU, potentially ICU.
I totally agree. I think in India, the challenge we are facing is, like Dr. Anshum just told, the use of, it's obviously wrong, a wrong use of nebulizers at home by children, nebulizers at home by, a lot of people, both patient driven because it's more affordable now and people do buy it, and also doctor driven. Often doctors are not aware of what they're doing in the days. So I think that is something that we all need to fight, that there is a place for nebulizers. We have an Indian guideline on that, but then there is overuse which we need to recognize, and then we need to correct that as well. I think that is going to be a challenge for many of us.
Yeah, and can I counter that by saying that, but it is also true that a lot of meta-analysis and reviews have looked at PMDI plus spacer and its equivalence to nebulization.
Yes.
So this kind of drives most of the physicians to, consider nebulizations, almost at the similar time as a PMDI spacer, as a, that it's synonymous, and your PMDI spacer may do just the same like the nebulizer, but then they also say that since the patient is able to take it more easily passively, so he by default gets the nebulizer when he's sick and does not take the PMDI spacer at that time.
Again, can I add on to it?
Yes, Dr. Nagar.
Yeah, I think it's just that the sale of nebulizers is not regulated, and patients can themselves pick it up from the pharmacies. And I think that is one main factor which drives more use of irrational use of nebulizers. I think things have gone a little better in the recent past because of lot of education being happening, emphasis that the drug delivery from nebulizers is not optimum, and if it has to be recommended, it's only under oxygen and under medical supervision. But I think there is a lot more to be desired to change as well.
And to that, I'll just add that there is an element of expectation also from the patient when he walks into an ER, that he's been receiving a particular device at home, be it a DPI or a PMDI or a BAI. When he walks into the ER with an exacerbation, he expects something different, right? And that's why he's probably being given a nebulizer. That could also be there, that, he's got something different when he's walked into the ER. All right. So moving ahead further, we have PRISM and pre-COPD, which is now being picked up more and more thanks to the guidelines, the GOLD guidelines, which brought about these new terminologies for us, and also the advent of oscillometry, which is able to pick up more and more of COPD, which is probably falling into the category of PRISM and pre-COPD. So how would you manage PRISM and pre-COPD? Would you prefer to use a short-acting or a long-acting drug? Or would you like to just follow up these patients as is what guideline recommends and call them for a follow-up after 6 months, 1 year, etc.? What is your experience? Dr. Sanjeev Nair, over to you.
I think PRISM and pre-COPD, once they are with us, they are with symptoms and they expect a treatment from us. And from the physician perspective, also most of us, me and my colleagues, at least in this part of the country, we generally do treat them. It's not that you keep them under observation. And most of our COPD, which come to us, are in COPD group E and all, they have frequent exacerbation. Many of them are triple regime, whereas with your PRISM and pre-COPD, we are with the mildest form of treatment. Either it may be a SABA-SAMA combination, or we might be on a LABA alone, which is given to the patient. But obviously, we do treat them. We don't wait to see what actually happens.
Right. So you do put them on either a SABA-SAMA or a LABA combination, depending on the need. Right. Professor Osmani, what do you generally do? So you're speaking on mute if...
Okay, no, sorry. Yeah, no, sure. So following at the moment the way that the guidelines are doing, not because it's the guidelines are the rule, but actually there is always adverse effects from intervention with drugs.
Right.
And so at the moment there are early cohort studies in Germany and UK. There's work being done in India to follow cohorts. There's work being done in China to follow these cohorts, and that will give us a little bit more of an information with respect to what's going on. I think the role of PRISM and the role is very much for us to really focus our efforts on early detection now and to reinforce the points of early detection rather than start treatment.
Right.
So that's the approach that we would take.
Okay. Dr. Anshum, you wanted to add something to it?
Yeah. I think what I do is I like to use this as an opportunity to stress on them that COPD is just around the corner in future. And if we don't make efforts to prevent it now, that is going to happen. So if it's a smoker, then this is a perfect time where, you can show them and tell them that smoking cessation is the way to go forward. And a lot of them positively react to it because we are able to tell them that there is a change in your spirometry. And for short, maybe a SABA-SAMA combination, if they have symptoms for, like a short-lived treatment, but I don't usually then continue it for a longer time, only if they're symptomatic. It'll be for a very short time to tell them that, see, this is what it is as of now, but it will definitely escalate if it happens in the future. And then take it off and just follow up the patient.
So follow-up is of utmost importance, correct?
Yes.
Follow up all of these patients.
Yes.
Okay. Right. Coming to the last question, and if we have any further questions from anyone across the panel. We'll take them post this last question. So Dr. Soumya Nagarajan, we spoke about SABA-SAMA, long-acting bronchodilators, in PRISM, pre-COPD patients also. So what do you think, or where do you think is the role of SABA-SAMA combinations, particularly in pediatric patients?
Yeah, very relevant question. I think in pediatric asthma, especially during acute episodes, mainly so in older children and adolescents, I think this could be a very effective treatment option, because as we know that SABA alone we do not recommend in children more than 6 years of age, and
Right.
yeah, so I think we do give it in combination with SABA and VCS combination. But SAMA, like ipratropium, complement our short-acting bronchodilators, especially salbutamol or other things, by providing an additional mechanism by because they block the muscarinic receptors, as we know, which helps mucus production definitely, and especially when children are having this acute exacerbations. Again, they say that it may not be just wheeze alone; they also have some degree of mucus production which is ongoing, which is not being relieved only by SABA alone. I think that's where it's in this effective combination, two-in-one medications would definitely be beneficial, especially in emergency settings, because it also not only using the combination, the effectiveness, enhanced bronchodilation is enhanced when given in combination. So I think this definitely has a very unique role in pediatric asthma in older children and adolescents.
Older children and adolescents. Okay. Anyone would like to add something to that, to what Dr. Nagarajan has just mentioned? All right. So I think very interesting discussion today. Thank you all. We've already overshot our time. It's 9:35 almost. So any concluding remarks from all of you all? We'll start with Dr. Kalpesh Panchal. So concluding remarks from your end.
So in my opinion, in a treating of obstructive airway disease patients in different setups, like in primary care clinics, by physicians and by general practitioners. So in this segments where they don't have an adequate knowledge of different kinds of inhalation therapies, we pulmonologists do know each and everything regarding the various devices and various options available, but the physicians and general practitioners doesn't know the various combinations, various types of devices. So I think we should teach them and we should educate them to fill the critical gap between the various inhalation errors and the facing the recurrent exacerbations.
Great. So teaching of utmost importance, critical. Dr. Nagarajan, what would you like to add, particularly for the pediatric segment?
I think one thing I have found difference in our educational outreach is not only for the physicians, as Dr. Kalpesh was telling, it's also for the assistants or the pharmacists. I think we have seen that when we run short course educational outreach programs, especially for the assistants or the pharmacists, it has made a lot of difference. The value they bring on to the physicians or the respiratory physicians practice. I think that's one thing, and especially not only assistant, I think it is good educational initiatives for parents as well. I think that makes a difference in the pediatric population.
Okay, noted. Dr. Anshu Maneja, what would your concluding remarks be?
I think, like we had started, the devices have to be the hero of the future, because we do have very good molecules. And I think it's time that all MDIs should, with time be converted into breath actuated, rather than, knowing that most patients will not take a normal MDI properly. And more integration of digital inputs into an inhaler may also be something that in future can really help us, with the inhaler itself giving, say, a green tick, or an LED lighting up when your inhaler technique is good, vis-a-vis not knowing what has happened, where it's going. So I think it's really important now that whatever comes in future comes with more precise technology, and because we know that the molecules we have are pretty good at hand. So that's
Okay.
something that has to come
So
up.
digitization or innovations in the device technologies, right?
Yeah.
Dr. Sanjeev Nair, your concluding remarks, sir.
I thought we had a very good talk from Dr. Usmani, and I'll take his message forward that it's the devices and matching the devices with the right device with the right patient, which is going to do a lot of good. It's not just choosing the right drug, the device with the patient has to be chosen. I'll go with Dr. Panchal, he said that we need more efforts from our side to increase the knowledge about the devices, like it was discussed in the discussion earlier, that the fact that the nebulizer can be matched with a breath actuated inhaler or a MDI with spacer is not well known. So such things can be taken forward. And I would also re-emphasize that there is overuse of nebulizers, which can be, physiologically, there are other devices which can give you the same kind of, for example, at least in India, use of MDI with spacer during exacerbation is quite uncommon. It's not even though all guidelines are moving towards that, in India, it's all nebulizers. I think 99% of patients are on nebulizers. So the option of using a MDI with spacer is during an exacerbation is not often considered at all. So I think there is a need to disseminate all this and improve the use of the right device for the right patient.
Okay, fair. Professor Usmani, last words from you, sir, please.
Well, it's been brilliant. I've really enjoyed the panel discussion. I'm not going to add anything more to what has been said by the panel in terms of education, multidisciplinary devices, multidisciplinary team, maybe the use of PMDI in space in the acute situation. And the final thing is, in that 3 minutes that you have with your patient, please spend 30 seconds on the device that may be the magic bullet that actually will stop them from having more and more treatments that may poison them. Spending time on that device that actually may allow the light bulb moment in terms of they are improved in their asthma control and their COPD control. So that's the one thing that I would say. But thank you very much for the invitation. I really enjoyed it. I've learned so much. I always do from this. And it was great to have the fireside chat as well. So thank you for the invitation.
Thank you. Thank you so much. I think very, very interesting points we've received today. Of utmost importance, right device, right drug, and right technique, right teach back. Many, many rights we have understood today, which all comes from what Gold has repeatedly, over and again, over the years, in all its updates mentioned that correct selection of the device according to the patient and the drug availability is of utmost importance. So great. Thank you all for having accepted our invite and being here on a Saturday evening at India. And thank you for the wonderful session. Thank you for all the audience to stay with us live throughout the event. And over to you, to Sanjana. Thank you so much, everyone.
Thank you.
Thank you so much for joining us. I think we can close the session.
Thank you. Have a good evening and a happy weekend.
Thank you. Thank you, Dr. Rishika.
Thank you. Good night.
Thank you.
Thank you. Thank you, everybody. Good night. Thank you, sir.
So, Sanjana, thank you so much for all your help, all those slides, the toing and the froing. Thank you so much. I didn't want to say it at the outset, and then I changed those things. I was just not sure about the 20 minutes, but I think it went all right. And it was really nice to see that data as well. So thank you for all your help, Sanjana. And obviously, Rishika, we met in the RS India, and it was really nice to do this.
Yes.
Thank you for taking the time out. I know it's a nice Saturday afternoon for you, so it's nice that you were able to spend it with us.
Saturday is always a bit difficult, but yes, and we managed to get there in the end. So thank you for all your support, Sanjana.
Thank you. See you soon. Bye-bye.
All right, then. Take care, guys. Bye-bye.